Our last lecture in the first session today with the title of Alzheimer, Mental, Physical and Speech Ability in Later Stage of Dementia. We are happy and proud to have Dr. Wahhabi with us. Dr. Fahad al-Wahhabi is psychiatry, geriatric psychiatry. He's one of the establishment of the Zahaimer. He was the first heading the scientific committee of Alzheimer disease. So please welcome Dr. Fahad.
Assalamu alaikum. I'm very cautious of time. I understand this is the end of the day. I'm not going to take a long time. I'm not as well informed as my colleagues, so I'm not going to hammer you with data, facts, and numbers. And I've decided, for the sake of practicality, to focus this lecture on using practical approaches to management. I hope this would be useful to those of you who are healthcare professionals or those who, God forbidden, have a family member with Alzheimer's disease, dementia, and have been involved or would like to be involved in improving the care that those patients receive. So this is going to be a short presentation. It's about 10 slides. The ideas that I'm going to present, you like this, صح? Dr. Hashim Balbaid likes short presentations. Obviously, he needs to move. He wants to go somewhere else. So what I'm going to do is to go directly into business and ask you or ask yourself this question. So we have a title of a lecture here, and I think tomorrow my colleague, Dr. Abdullah Sahel, will go into details about the palliative care of patients with advanced dementia. But whenever you hear the word late and early and middle, you have to understand what that really means with no confusion. So the first question, how would I recognize the latest stage of dementia? Whether you are, or me, or anybody else is a family member of a patient or a healthcare giver in a hospital or a clinic. So if you go through what we call dementia staging, most chronic illnesses or diseases have staging systems. We know this very well with cancers, probably not too well with other more common chronic illnesses. However, with dementia, not specifically Alzheimer's disease only, but in dementia in general, there are different staging systems. Those are the ones that are commonly used in research setting and even in some clinical programs. So they're abbreviated as GDS, or Geriatric General Deterioration Scale, FAST, Functional Assessment Staging Scale, and CDR, or Clinical Dementia Rating Scale. And what I'm showing here is the correlation between these systems. What we are concerned with today is the rows with the dark blue color. So terms like moderately severe dementia, moderately severe Alzheimer, or CDR3 pretty much mean the same thing. And that thing that they all mean is a phenomena where you see people who have a long-standing dementia that got them to reach this stage where most of these features, or all of them, actually exist. So you see someone who has significant difficulty running their life independently. Their language abilities or speech abilities have declined. Their ability to communicate has been has deteriorated so much that they have difficulty expressing their basic needs. So I think most of us, even the non-informed, wouldn't have a huge problem recognizing that a patient is in a later stage of dementia or has a severe dementia. But for the sake of clarity, we have to make sure that this is what we are addressing now, for a simple reason that these patients would not be able to express their needs directly, and therefore there will be lots of guessing going around either by the treating team or family members. Second question, how can I be useful to patients in these late stages and their families? It's a very common question that healthcare professionals go through. You have somebody who has a terminal or semi-terminal illness. So in between brackets, no hope. Or somebody might feel that there is no hope. How can you be useful when you think that there is no hope? There is a huge difference between experiencing a terminal illness and feeling useful or being useful at that stage of the disease. So with that being said, what we are going to go through in the next 5 minutes, potentially, or maybe even less, depends, is describing how can we be useful in these stages where hope is gone or lost. So this is the most important slide in this short presentation. Please take a look at it and make sure that it sticks in your mind photographically speaking, if you think that you might be involved in a care of a patient with late stage dementia or advanced dementia. So going from left to right, prioritize and simplify, review and modify, manage anxiety. And that would be the anxiety of the family, not the patients. Although patients sometimes might be anxious in those stages, but I'm referring here specifically to the family. Okay, so let's start with the first one, prioritize and simplify. In this stage, which is usually the stage of your primary involvement with those patients at this stage, I'm sure everybody knows that at this stage you have to do your assessment, you have to ask questions, you have to get answers, but you have also to establish habits. And those habits are habits that has to be habitual in the way family members and the caregiver are deciding what is the priority at that stage. So at that stage, as you can, at least that's my personal opinion, you can classify the priorities at 3 different groups. You want to assure safety, you want to prevent medical emergencies, and you want to improve the quality of life. So improving safety might be done by ensuring that risk of falls is assessed and taken care of, that aspiration risk has been looked at, acknowledged, and dealt with. Because if you don't have those sort of priorities there, that patient who might be taking the best medications in the world is at a safety risk every day. The second priority is to prevent medical emergencies. Those patients typically take lots of medications. Every day, their family members might have difficulty administering some of those medications. So if you are a member of a family of such patients, there is 10 medications you're trying to give, and your patient would not accept taking more than one type. Which medication would you give? Are you going to give Centrum, or are you going to give them their hypertensive medication? You have to decide, but again, it's a priority issue. So safety, prevent medical emergencies. Another example of medical emergencies, which is quite preventable, patients who become delirious, admitted with septicemia because of a UTI. When their UTI is treated, you want to make sure that that UTI doesn't recur. So the first thing you do after completing a course of antibiotic is checking their urine again, because if it's not clear, that UTI will relapse within a few days or weeks, and then we're going back to the same problem. So there are very simple things that could be done to prevent medical emergencies. Simple things that could be done to assure safety, and simple things that could be done to optimize the quality of life. And I'm going to go into that in a few details in a minute or two. The most simple example of optimizing quality of life is improving pain control. Again, if a patient does not have enough pain control, they're probably not going to sleep. They might be aggressive. They will look obviously confused and tired and probably more disoriented than usual. You can prevent that with a simple pain control. However, how would you know that that patient has pain if they don't express that? You have to open up your eyes. So what you're doing at this stage of the assessment, which might be news to you but not new to the family, is that you want to make sure that all these things, I call them things, just a generic word, are done. These 3 elements of establishing habits. So if it's not a habit, it's just going to happen in a random way. Things that happen randomly are not great with patients like this. These are very fragile patients. They go into trouble easily. So establishing habits is important. The next stage is review and modify. So what happens in a month or 2, or when they progress more? What you would be doing during that time is making sure that you're reviewing the habits that have been done or established before, and wondering if you need to establish newer habits. So at this stage, you want to ask questions that could modify the already present habits or bring up new ones. So commonly, family would say, we take our family, probably everybody here understands what I'm saying. We take our patient, our loved one to al-istiraha at the end of the week. And he comes back annoyed and becomes aggressive for a day or 2, even though he used to go to that istiraha and loves it. And just with the brief questioning, you would understand that istiraha is full with like 50 people who this individual, this patient, has forgotten their names, and that becomes an extensive amount of sensory stimulation that they can't cope with. So the question is, do we need to continue doing this habit of going to istiraha every week? Do we have other habits that are more calming, less demanding, and less stimulating sensory-wise? And you go through all of the 20, 30 habits that happen every day to that patient, which will probably happen to us as well. If you check your own personal life, you'll see that there is at least 15 habits that you do every day. But you're smart, you're cognitively intact, you can do them. Those patients can't do that same amount of habituation, and they probably have more habits because of their medical conditions. So there's 5, 6, 7, 8, 10 medications that they need to take. They have 2, 3, 4, 5 side effects that are resulting from those medications, and they have to meet their extended family every day or every few days because that family thinks that they need to do this to make the patient feel better. Do they? You have to ask yourself, does that make patients feel better? Do they need to be bathed every day even though they don't really have to, but because they used to do that 3, 4 decades ago? Okay, so every habit that creates problems or risks or does not provide further benefits have to be checked, reviewed, and adjusted. And that would include using medications. And that is a very sensitive, common question that gets addressed in a psychiatric setting where patients take psychotropic medications to sleep better or to, subtle aggression if that was part of their presentation. Those medications have to be reviewed every few months. Nothing stays there forever because you have a patient that changes quickly, neurologically speaking, physically speaking, and otherwise. And then managing anxiety. So you have a family member who probably have mixed feelings about what happened. They're trying to be caregivers for a patient population that they have never been trained or told how to do this perfectly well. They probably have mixed emotions from a variety of other settings. There are husbands and wives who care for a family member or a life partner who have had tumultuous relationship with through the years. Many of them have guilt feelings about what's going on. Many of them think that they have caused this in some way or the other. So they have lots of questions in their heads. They're struggling with what they have to struggle with. And however, at the same time, they're trying to be excellent caregivers. So you have to understand that that anxiety reflects in the care that those patients, those family members provide. And one of the questions that get addressed, are we doing enough? Are we doing too much? Do we need to do something different? Do we need to report everything that we see? Or not everything needs to be reported. There's lots of things that happen every day for a demented patient. What would need to be reported to a physician? Should they write you a list? Should they write you a sleep hygiene schedule? Should they tell you when did they wake up and when did they sleep? So part of helping them might entail helping them to contain their anxiety by trying to convert care into a concrete activity that they can do, knowing that this is what would be required to provide reasonable medical care. So they don't really have to count how many times did the patient pee during the day. But they need to know that if that pee's smell has changed or color has changed, then they have to report that. So very simple tips like that would help the caregiver, especially the family who are not trained to do that, to do what they have to do. So again, going back to that slide, does this slide look sensible to you in general? Okay, so that slide that could be interpreted in many ways is to me what represents the main frame of looking after patients with advanced stages of dementia and managing their family's anxiety. And of course, the content of this slide, which I had just presented, has to go through the same priorities that I just said. It would have to be reviewed, it would have to be modified. This patient population changes with time. We have to be able to cope with that. So with that being said, I reached the end of my presentation. Thank you, and I hope that was clear enough.